Good afternoon, and thank you again for joining us for our COVID weekly webinar ahead of the bank holiday weekend. Before we get stuck in this week, just a quick reminder that on June the 5th, we are doing a special Q&A session, an hour-long session where we're going to invite questions from you in advance to our panel and have a broader discussion than we have done in the other sessions. There's going to be a survey at the end of this for you to put questions down, or you can add them in at the side as we go along, or send questions into NHS Insights at mtechaccess.co.uk. Also, just to let you know, we've launched a new page on LinkedIn, an NHS Whispers page, where we're going to be bringing you more insight and commentary from inside the NHS as part of what we do. So on to this week's webinar. This week we've seen a slight increase in activity in the NHS, hints of a return to normal, but all tempered with a lot of concern about the public perception of the restriction easing, potential likelihood of a second wave coming along, which we might touch on at some point today. It's a very confusing time. Last night, me and my wife were looking at our school returns policy and trying to figure out what all of that meant for us and the children. So, yeah, as we go on through this crisis, it doesn't get any easier for any of us, really. But what we're going to be doing over the next couple of weeks is looking at the changing face of care delivery. So previously, we've looked at all different parts of the NHS and what has been happening and how they've been responding. Now we are going to be looking a bit more forward to how the NHS is organising itself and what some of the lasting change might be. So this week we're looking at system and hospital level, and next week we're going to look at primary and community care. So we're very lucky this week to have two people that have been right at the coalface of dealing with COVID in their respective areas. We've got Berenice Groves, who's the Director of Operations at Blackpool Teaching Hospitals, and we've got Tina Teague, who is currently the COVID Resilience Manager for Devon, and they're going to be giving us their views on what's been going on locally for them. So Tina, welcome, thanks for coming along. Just coming to you first, you're obviously working across the whole system in Devon. So can you tell us a bit about what you've seen at system level and how the NHS has reorganised itself to handle COVID?
Great, thanks, Tom. I started working with COVID probably around March time when it kind of kicked off, and we were expecting a peak at Easter, and my focus was around creating the kind of resilience in primary care to avoid as much as we could possible impact on the rest of the system. You know, it's really interesting because it was fantastic to see how quickly different parts of the system responded, and there was a genuine breaking down of boundaries, and everybody got stuck in to do the right thing to get things moving quite rapidly. And we you know, we did major scale transformation in the space of about 14 days that, you know, perhaps in the past would have taken 2 or 3 years to do. So it was really good. So, you know, kind of for me, my main observations were, you know, the rapid response with no boundaries, and also the coming together of organizations. So it felt like the system came well together, really good, and responded quite well.
Did you feel that any parts of the system were better equipped or worse equipped to respond?
So I would say, because of the observations made nationally around what we had seen across the country, the idea was to protect secondary care as far as we possibly could. So I would say that it kind of felt to everyone that was the right thing to do, to avoid you know, overburdening secondary care, but it didn't feel like you know, any part of the system was treated differently to another. It felt that there was collective agreement that was the right approach and the right thing to do, and all the kind of partners came together to enable that to happen.
And that's really interesting, because that sounds like a, you know, forgive me if I'm speaking out of turn, but that sounds like a quite a new thing within the NHS, that everyone's kind of buying into the same vision. Did it feel like a change in culture and that things were being done in different ways?
Yeah, absolutely, Tom. I've spent 20 years of my career working in service transformation in the health service, and it was a dream for me to see, some things that maybe I tried to do 20 years ago that I started in my career were happening overnight. So I think it was genuinely new territory and a different way of working for everyone. And people were excited, and everything it was happening quite quickly, and I think that that was really a good thing. So yeah, you're absolutely right in your observation.
Good stuff. Berenice, just for everyone's benefit, we can't see you, but hopefully you're still there on the phone. Just coming to you now. What are the most notable changes you've seen within your trust in how care is being delivered?
Hiya, Tom, and apologies that you can't see me today. I think just to introduce Tom, so obviously I am the exec director of operations here, but I was appointed as the strategic incident director for the trust to manage COVID through the period. And just to say that we actually started some of the planning that we put in place right back in February, and it seems an awful long time ago when we started to develop pods for people to come and get some swabbing to be done, and all managed through a very, very small emergency department. When this really kicked off in March, late March time, I think, as Tina's quite rightly said, one of the best parts about it is the transformation and the service improvement that's happened very, very quickly. We're really bureaucratic. We do business cases to death. In our own organisation, a business case can come through 5 times before we signed up to it. And really, within a matter of days, we were making decisions, and we'd actually introduced proper command and control where we were able to authorise the finances and obviously authorise the changes that needed to happen. And that's because of the pressure that we were under in the organisation. We needed to make it safe for patients actually coming into there. I mean, I can go into some of the changes, but I'll hand back to you.
No, I mean, it would be great if you've got any sort of specific examples of some of the changes that you brought in, sort of any of the sort of operational or structural things that you've done differently that really sort of summarize how things have gone. That'd be fantastic.
Okay, so some of the things that we did very, very quickly is we started to really embrace the use of technology, which I'm sure everybody will appreciate across the board. It's been a real fight. We've had consultants that absolutely have refused point blank to take on different ways of working. And within days, we stood down face-to-face consultations for outpatients, and we've set up the use of technology to allow us to attend anywhere across our organisation, and certainly across our ICS, which I know you'll come on to. And very similarly to that, primary care and our community services were used in this as well. So linking into care homes and nursing homes to provide end-of-life support and palliative support and reviews of patients through technology. The management of patients. So one of the things we did recognise through the outpatient changes that we made was that sometimes the contact, especially for the shielded patients that they had through our follow-up referrals, was the first contact that some of these patients had had for a long time. So managing to link them very quickly into other services. And I think that's the best bit, is about how all the providers have really linked up closely. So it didn't matter whether we worked for the mental health or we worked for an acute trust or worked in the community. Everybody would sort of share resources and support each other. The other area was around access in the independent sector. So you'd be aware that the government signed up contracts until the end of June to provide additional resources and capacity through the independent sector, an area that we didn't really have a lot of access to before, so that we could keep some of our cancers and non-urgent operations continuing. And another one just to highlight was just location of services. So some time back there was a direction of having the urgent treatment centres co-located within our acute trusts, so that we could link those in very much with our emergency departments. And literally within 2 weeks, we'd actually moved that service out, lock, stock and barrel, to a kind of primary care centre facility to provide us more capacity. But actually, as a result of it, improved some of the pathways, and they will absolutely remain. So I'll stop, pause again in case there's any questions.
That's all fantastic. Thank you very much. I mean, one thing that you mentioned right at the beginning there was about the sort of the pace of change, I suppose. Well, I was going to say the elimination of business cases, but at least the sort of taking a different approach to how things are being done. Do you see that as a cultural shift now within the trust? I mean, a lot of our audience are, very interested in redesigning services and pathways and those sorts of things, and I think we've all, through our various jobs, experienced kind of that frustration with how long it can take to get things done. Do you see that as being a lasting change now?
I do absolutely. One of the things we did really quickly, and although it wasn't there right at the start, because I am aware that we were almost developing processes as we were reacting to situations, but we put in a very good close governance process around capturing all the changes, how the decisions weren't being made. Part of that was having really good, strong clinical engagement, something which had been lacking before this all kicked off. That's been a really positive addition, really, to all of this. Because of that, and people could see the benefits, and we are continually monitoring and auditing the benefits as we go through. We were actually asking people for sort of what we call change oversight logs, to put changes back to how they were before. So it will be a case of, if this change and this pathway is working better, why would we ever go back to what we've done previously? And also, as a result of that, we've proven how quickly, by people working together, a few strong heads, we can make a change really, really quickly.
Yeah, absolutely. And that's something we've heard throughout our series from all parts of the NHS is that sort of collective vision. And I suppose that the next phase of what the NHS is looking at, in, well, many things obviously, but the idea of kind of the return to routine care and trying to get some of those patients who maybe haven't been seen, all across the board. How do you expect hospital services to adapt to increasing that routine work? Just, I suppose, in my mind, thinking about, at the moment there's that shared vision around do what we can to get through COVID. As services are starting to again, are they going to be the same way?
Yeah, I suppose, Tom, this is probably one of our biggest challenges. So it's really easy in some ways, isn't it, to say, right, we'll stop and doing that. There's a lot of patients out there that said, actually, I want to stay safe, so I don't want to come anywhere near the place anyway. So that the actual activity drops down. But we do absolutely need to get back to making sure that people who have critical operations, life-threatening emergencies, that they actually do start moving back into the NHS and other services that are required. So we're currently, and this is not a done deal at all, it's been quite a complicated process. We're busy doing some modelling around all the organisations, looking at our bed capacity, looking at we're being hit with having to take, in our organisation, about 150 beds out of the organisation, and the pressures that we were under previously, but that's just in order to make sure that patients are safe and they're socially distanced while we manage them. So less beds, we've got to accommodate different pathways, and as we talk about kind of having a clean pathway, green pathway, and a red pathway for COVID positive patients as well. And on top of all that, it's accommodating access to the staff being available, the PPE being available, people's anxieties. So patients that were really, so if I give an example of 200 people being invited back for endoscopy and only 91 agreed to come back, it's the pressure that we've got with patients. So we're absolutely working through all of that, and we're putting all those pathways in place. And as I said, alluded to earlier, the use of the independent sector is being a massive benefit to us at the moment to try and help us out with some additional capacity.
Fantastic, thank you. And in terms of, obviously, there's countless services within the trust that you're going to need to remobilise at some point. How are those decisions around prioritising being made? Which services take priority over others?
Yeah, well, it's very, as I say, it's very clinically driven. So we're very lucky. We've got a really strong medical director. If anybody wants to go on to any of the websites, he delivers really good, clear patient messages on a week-to-week basis. One, trying to encourage people to come back into our services, but also remind us about how to keep people safe. So he very much leads that clinical prioritisation, and in the first and foremost, it was absolutely about the urgent that were identified ages ago, and the cancers. But they also looking at, so even if you look at kind of some of the orthopaedic operations, we could end up affecting somebody's mobility if we don't crack on and do something about that as well. So the clinicians have a panel, and they work through that to agree which is the priorities, and then it's about encouraging the patients to come back.
Brilliant. Thanks very much. So Tina, coming back to you, obviously we talked there a little bit about how pathways are changing and priorities are having to be sort of decided upon. In terms of a lot of the changes that you've seen locally around how patients are being directed and what's happening with the pathways, do you see a lot of those changes lasting yourself?
Yeah, so Tom, I just want to kind of add on to something that Berenice just said, which is quite interesting. So I totally agree with everything she said, especially around trying to persuade patients to come to access services. And one of the things that we're quite worried about is this kind of the implications of the delays, because we've already seen that now in primary care that we've sort of relaxed the focus a little bit because we don't have the numbers of COVID that we were anticipating. We're worried that the patients who are presenting with higher acuity, so they've been hanging on to their illness for much longer than they would have in the past, which has got implications, and we can't persuade them to go to the hospital for the reasons that Berenice was just saying. So we have a real issue about how that the system reconnects with at higher acuity presenting later, and obviously the acutes will have a backlog that they need to catch up with. So there are some issues about how we work around that. But to answer your question is that it's interesting because we're going through a similar process as well. So we're doing something called rapid learning cycles. And basically this is a process of going, because the thing about change is you want to capture it whilst it's happening, because if you don't, people forget very quickly. And there are some people getting twitchy going, I want to go back to normal. There is no normal, this is changed forever. And we need to look at what the new normal is. So we're doing a process of rapid learning cycles, which is about analyzing as things happen very quickly. What do we like about this change? How did it come about? What do we like about it? What do we want to keep? What do we want to change? and so rather than gain, we will stop doing this. It's, what could we improve about it? Because if it's a good change and if it's a positive thing, then we want to keep it. And a few examples of this is, this is one of my favorite stories, and it's related to Berenice's point about the video consultations, is that there was a patient who had a video consultation with an acute consultant, and they were able to add his GP into the consultation. So, how amazing is that, to be able to have a three-way sort of system connected consultation, beneficial for the patients, educational for the primary care clinicians, good for secondary care because they can connect with the primary care. And that's really, part of the really good initiatives that we don't want to lose. We've reduced the need for patients to travel. We're triaging patients more, so we're saving patients some unnecessary journeys. So we don't want to go back to anything that was beneficial for the patients or beneficial for the systems. We really want to make the most of keeping those changes going.
Yeah, thank you. And I mean, that example is incredible, and I suppose it's what people have dreamed of for years. Do you sense that there's a bit more of a shift in focus towards the patient being the centre of care, which is, we've talked about patient-centric care for years, but again, the system hasn't always executed it properly. Do you think that's going to change?
I think it's more about the kind of the multidisciplinary team in its wider sense around the patient. So, absolutely what's the right thing for that patient, but how do we as a system work collectively to deliver what's the right thing for that patient? So rather than putting our own organizational needs as using them as potential barriers for doing what we need to do, I think it's really good that we have learned that we can collaborate. We have learned that we can take a multidisciplinary approach and set aside our organizational boundaries. So we should do that, and it's a really good thing to be able to see primary care, secondary care, the voluntary sector, the local authority, community services, all connecting around, what's the right thing to do for those patients. And another one of the examples I can give you is, we've got a lot of anxiety around patients who are shielding, because some of those patients, they will be our patients who are most vulnerable and will be on that list for flu vaccinations. And we're already starting to think about, rather than each of us inviting patients for flu vaccinations as a system, how do we capture, it doesn't matter who gives the patient the flu vaccination, where's the safest and the best place to give the patient that vaccination? Is it someone who's going to their home for something else that could just give them their vaccination? Is it a car park in the supermarket where that vaccination can take place? Is it whilst they're in secondary care having a scheduled appointment done to minimize that footfall and the contacts that the patient has to interact with? So for me, that's some of the things that you and I would describe as patient-centered care, but it's an MDT approach about the system working together.
Yeah, fantastic. And it's really interesting because in the first webinar we did, which is probably 8 weeks ago, something like that, right at the end, I asked for a one-word answer on whether the panelists thought this was, a real shift in the move towards integrated care, and they both gave a one-word answer of yes, which was very encouraging. I suppose thinking about that system perspective, and I'll come to both of you with the same question, where obviously there's been huge amounts of positive change and there's a real sort of clear desire and direction of bringing things closer together, where do you think the biggest risks are in seeing that through and following it through so that we are achieving that? I'll come back to you, Berenice, if I can, with that.
Sorry, Tom, the biggest risks in delivering?
In kind of the move towards integration of services and the collaborative working piece.
The human factor, really, because what we've had is a burning platform. We've all responded to it, and we've responded well to it. But then it's so easy for people to just go back into their own organisation. Finances start to affect how we're working, and I think Obviously, the government's travel was about developing the integrated care services, the integrated care providers, and this has really pushed us down that. We've developed cells across the whole of the ICS now, and we're even now looking at, are we going to deliver cancer services in this hospital? Are we going to deliver, oncology in this hospital? So it's really pushing us to do that. So it's only going to be us ourselves that let that happen. We can push this forward. Yeah.
Does it feel like there's a bit of a need to crack on and sort of get some of the changes affected so that people can't ebb back from that again?
I absolutely do, and I think that's why they've agreed to keep, well, it's certainly a level 4 incident now. They've asked us to keep our incident control centres up and running at least until the end of March time. So I think if we work in this way, we can keep the momentum going and work together to embed some of the collaborative changes we've been trying to do for the last 5-6 years, as Tina says.
Yeah, wonderful. Very optimistic outlook. We like that. And so, Tina, coming to you, I think same question about where do you see the risks to sustaining some of the change?
So I agree with the human factor, because it worries me when I hear people saying, when can we go back to normal? So that's the thing that worries me, because there's this kind of psychological, this is temporary, I need to go back to something else. That's my first one. I guess for me, the second one, which no one is talking about, or unless they're talking about it, but I've missed it, and, Berenice will be more at the forefront of this, being in the acute trust, is so all of the kind of boundaries were broken down when we had to respond to COVID. And by that, I mean, quick plans, SIP, whatever you want to call them, those kind of cost improvement plans, which freed up people to think creatively about what are the right things to do and the right services to put in place. And I suppose I'm worried that we're not talking about kind of what I would describe as payback. They will be, there'll be consequences on the impact on the economy and everything else. So I guess I'm a little bit worried about, whilst the creativity and the willingness to work together is what might come round the back to bite us, and will they be announcements about cost improvements that will need to be made to bridge the gap about any spending that was made. So I guess for me that would be the greatest risk, is that if we undo all the good stuff that we've done, because we've been presented, particularly the acutes who are always facing this problem, we get presented with a massive financial recovery plan, which means that there may have to be some challenges.
Yeah.
Have you got a quick comment on that then, Berenice?
No, I agree. I mean, I said very quickly, I said finances, because we've been in a very different place lately, where it's a case of if you need to spend, you can do. In the last couple of weeks, we've been starting to get the direction back of no more capital spend without it following this process, have to get agreement from the central teams. So that just starts to delay things, and as Tina says, it starts to show the shoots of trying to push things back to normal and save and making costs. So if we continue to work together in the way that we're actually doing, we actually will save money. But if we stop it and say cost improvement plans, we'll go back to how we were. Yeah.
Wonderful. Well, thank you both very much. We're out of time now, but yeah, thank you both so much for your insight today. That was hugely valuable, certainly for me, and hopefully for our audience as well. Thank you everyone at home for joining again. I hope you all have a good bank holiday weekend. Just a reminder that next week we're looking at the changing face of care delivery from the primary and community care perspectives. The following week, June the 5th, again, a reminder, if there's any questions that you want to ask of some of our panelists from the last few weeks, send them in now. There'll be a survey that follows the webinar now. If you want to submit any, we're going to have a look through all of those and pick out the most common ones to put to our panel. So thanks again, everybody. Have a good weekend, and we'll see you next week. Bye.
Thank you.